Hello, and welcome to this BSAVA webinar, The Jaundiced Dog. My name is Fergus Allerton. I work at Willows Veterinary Centre and Referral Service in the Internal Medicine Department. I have no relevant conflicts of interest to disclose, and so we'll jump in with this webinar. Now, it was intended to be an interactive session at Congress, and obviously for unforeseen reasons, has been translated into a webinar. I would still encourage you to shout at your computer to try and answer some of the questions that I'll pose and to see if you can work out the diagnosis before I do. I hope to cover a bit on the pathophysiology of jaundice, how do patients become jaundiced, and this is a bit Blue Peter-esque, but a small animated video to show that pathway. We'll look at different classifications of jaundice: pre-hepatic, hepatic, post-hepatic jaundice, and then cover 3 different cases that illustrate different presentations of this clinical sign. This is going to be focused on canine jaundice, and so this is the only non-canine. This is a minion who is likely jaundiced due to excessive consumption of bananas. Anyway, this is the metabolism of bilirubin. It's worth remembering that red blood cells produced in the bone marrow will spend about 110 to 120 days in the circulation. But eventually they become old or they become damaged and they need to be cleared out. So it's macrophages in the spleen or liver, Kupffer cells, that will break down the hemoglobin component of the red blood cell into globin, which is recycled back to the bone marrow and used for future erythropoiesis, and heme, which is itself broken down into iron, again recycled for future erythropoiesis, and unconjugated bilirubin. Now, the unconjugated bilirubin is lipid soluble, so to be carried around in the bloodstream, it needs to be bound to albumin. The albumin will deliver this unconjugated bilirubin to the liver, and within the liver, it will be conjugated through the addition of glucuronic acid. That addition will create conjugated bilirubin, which is water soluble and therefore can pass into the bile and will be stored either in the gallbladder or pass into the small intestine. And you can see this passing through the biliary tree and either going into the gallbladder or passing further down and entering the small intestine. Through the small intestine, it will pass to the distal small intestine, eventually arriving at the ileum, where the conjugated bilirubin is metabolized by bacteria to urobilinogen. Again, water soluble, so 10% of it is quickly reabsorbed, while the remainder is rapidly oxidized by the bacteria to stercobilin, which confers the brown color to fecal material and is excreted from the body. So that's how bilirubin is produced and how it leaves the body. And there are various parts of that pathway that can be impaired, leading to different forms of jaundice. And so we can see an excess of bilirubin in the blood. We'll see icteric serum, so you might be spinning down your blood sample and notice a yellow tinge to the serum, and you'll pick that up from about 20 micromoles per litre. The optical threshold for the mucous membranes is somewhere between 35 to 50 micromoles per litre, so that depends a bit on how good you are at appreciating that yellow discoloration. And worth remembering that there are things that will artifactually push your total bilirubin up on certain analyzers, and these might include hemolysis or lipemia. So if you notice a significantly hemolyzed or a lipemic sample, do take with a pinch of salt your bilirubin reading. Delta bilirubin can lead to persistent icterus, and given the half-life of albumin of 2 weeks, you will see binding and potentially, especially of the sclera, persistent icterus if biddy protein is formed. No real difference. We've talked about how conjugated and unconjugated bilirubin are formed, but there's no real difference if you measure them. So actually you can't get extra information from comparing levels of conjugated or unconjugated bilirubin. That's not going to help you elucidate where in that pathway the problem lies. So trying to measure those different forms of bilirubin is not a helpful step, not something that we would routinely do. What forms of icterus? Prehepatic, hepatic and posthepatic. So prehepatic relates to excessive breakdown of red blood cells, leading effectively to an overloading of the processing system and therefore excess bilirubin escaping into the bloodstream. And we'll see that with any hemolytic process, such as immune-mediated hemolytic anemia, that being the most common. You will see it in kittens more with neonatal erythrolysis. And if you are not cautious with cross-matching secondary or tertiary blood transfusions, you will see hemolysis occurring with an incompatible blood transfusion. What about hepatic icterus? Well, any inflammatory, infectious, neoplastic, toxic challenge can lead to damage to the liver and effectively the liver will either not be able to perform the conjugation and won't be able to excrete effectively the bilirubin that's being generated, leading to intrahepatic cholestasis. And we also see this with cholestasis of sepsis. But you might find that the liver's doing everything right. It's processing the hemoglobin, turning it into bilirubin, managing it, and the liver's doing all that absolutely fine, but it's after production of the conjugated bilirubin, you're seeing obstruction to bile flow, and a post-hepatic icterus can be due to either intraluminal or extraluminal bile duct obstruction. Extraluminal, for example, might be pancreatitis. You can occasionally see cololiths that will cause an obstructive pattern and a build-up of bile, and they will domino back up, leading to hyperbilirubinemia. Gallbladder mucosal, another good example of impaired biliary drainage. If you do damage the cololiths, can also damage the bile ducts and cause rupture. I feel a bit like Joe Wicks, but there is a bird up here, and I thought I'd throw a question out there as to what the name of this bird is, and also, a bit like his what's the capital city question, anyone know what country this is the national bird of? And I'll provide that answer right at the end. So, 3 cases that hopefully represent different types of icterus in a rather predictable order, I'm afraid, but that demonstrate different aspects of jaundice icterus. So, this is Liba. She was a 2-and-a-bit-year-old female neutered Doberman. She'd been vaccinated completely up to date, not recent. I mentioned that in the context of IMHA. There is a link, or people will often speculate as the potential link to recent vaccination. Actually, the evidence, for that being causative of IMHA is very limited. So if you look at epidemiological studies, it's not significantly more than 1 in 12 animals who present with IMHA have been vaccinated in that previous month. So the role of vaccination in provoking IMHA is probably quite limited. Anyway, Liba had been a bit lethargic and inappetent for the last 3 days, but collapsed, prompting her urgent presentation. And on physical examination, we've already seen her gums and mucous membranes, but also her sclera were quite obviously yellow and icteric. Increased heart rate, quite fast for a large breed dog, and mildly increased respiratory rate, and a grade 2 systolic murmur. was present. Those mucous membranes are so yellow that you couldn't really even detect any pink behind it, and I suspect she's also quite anemic. And that would be supported by the increased heart rate and the presence of hyperdynamic pulses. So, just to start with the biochemistry, and you'll see there's quite a few asterisked abnormalities in this profile. The one that we're most interested in this seminar is the total bilirubin, and you can see that that is incredibly high. That's a very, very significant hyperbilirubinemia, maybe slightly exaggerated by the presence of ongoing hemolysis, but it does fit her sort of luminosity appearance. There are also quite significant increases in the hepatocellular liver enzyme activities, and I think this is an extra warning, and especially in Dobermans who do suffer from Doberman hepatopathy. I was a little concerned that there might be a primary liver disease as well in this case. The reason I say that is, well, actually the haematology in this case showed quite a marked anemia, hematocrit down at just over 17, and at this stage it was apparently non-regenerative, though I think strictly speaking we should call this a pre-regenerative anemia, as within the next, I think, 24 to 48 hours there was a marked reticulocytosis that developed. Also worth noting, there was a inflammatory leukogram with a neutrophilic leukocytosis, and there was also a mild thrombocytopenia in this case. So, back to our metabolism of bilirubin issue. This is an instance of overload of the processes of bilirubin breakdown. There's so many red blood cells that are damaged and are trying to be broken down by the reticuloendothelial system that the body is overloaded and is producing massive quantities of bilirubin and unable to clear them at the rate it's producing it, so that's why they're appearing in the circulation. So this is an example of pre-hepatic jaundice, and we're automatically suspicious this is going to be a hemolytic process, and we'll look to try and confirm that with additional appropriate tests. So examination of a blood smear, always useful to look for any indicator of regeneration. So we might see an isocytosis, we might see some nucleated red blood cells. They can be early indicators that we're going to see a regenerative pattern soon on our analyzer. But we're also looking for the presence of spherocytes, and in this case there were quite a few. Spherocytes are a key indicator of an immune-mediated hemolytic anemia, and when present with either a positive autoagglutination in saline or a positive Coombs test, that's sufficient to give you your diagnosis of immune-mediated hemolytic anemia. So really for that you need a regenerative anemia and two of spherocytosis and autoagglutination or Coombs test positive. And in this case, everything was quite positive. So we've got a diagnosis, immune-mediated hemolytic anemia. It's always important to establish whether that's a primary disease process or secondary. So imaging of the patient, thoracic and abdominal, to look for a focus of infection, inflammation or neoplasia is warranted, because if there is a primary cause or underlying condition, we should try and treat that. So I have seen IMHA secondary to pyometra, and therefore you just need to treat the pyometra. You can see it secondary to various neoplasias, and you're only going to effectively manage it if you can treat that underlying problem. There are certain blood-borne parasites that can be significant, so I would recommend, if there's a pertinent or relevant travel history, screening for those. I had a case of babesia in a dog report that just come back from Portugal 10 days ago, which is unusual given the current travel restrictions, but nonetheless That one had babesia, and a tick had been identified just after return to the UK. Ehrlichia and other exotic diseases worth testing for in certain situations. But when all those tests are negative, the default diagnosis is going to be primary immune-mediated hemolytic anemia, and treatment would be appropriate transfusion therapy. Think which is going to be the optimal transfusion product. Should you use whole blood? Should you use packed red blood cells? My recommendation would be to use packed red blood cells, because these animals, because it's a hemolytic and not a blood loss process, they're probably not going to be hypovolemic. So there is a risk of volume overload if you use whole blood, and packed red blood cells are going to represent a lower volume while replacing the essential oxygen-carrying erythrocytes. Immunosuppression is going to be the key to therapy, and I would use prednisolone. I tend to adjust the dose, and looking at the recent ACVIM consensus document, there is a dose range suggested, and I think this is often clinician dependent. I would tend to use lower doses in large breed dogs, especially a dog like a Doberman, which could suffer quite significant muscle atrophy with high doses of steroids. So I would probably use 1 milligram per kilogram twice daily for a maximum of 3 days before pulling that back. Now, I know other people would use that twice daily dose for longer, but I do worry that they do struggle with high doses of steroids. A smaller dog, you can probably get away with it, and sometimes they'll go 1.5 milligrams per kilogram twice daily for a week to 2 weeks, which will obviously produce some adverse effects, but then often better tolerated by the owners and by the patient. Use of additional immunosuppressants, no real strong evidence for any of them, and again, I think that decision may be based on the anticipation of adverse effects. So again, in a large breed dog where you feel that a more aggressive taper of the steroid is likely to be necessary, then an early introduction of a second immunosuppressant is going to be appropriate. Largely clinician preference again. I would tend to use cyclosporin, but I've got colleagues who might favour mycophenolate or azathioprine, and I think that depends a little bit on your own experience and adverse effects that you've seen in animals treated with these type of medications. Use of some form of anti-thromboembolic is going to be a sensible precaution. Unfortunately, IMHA is associated with a relatively guarded prognosis, with survival varying between 30 to 80% depending on different studies that you read, and lots of those deaths are due to thromboembolic complications. So the use of either low-dose aspirin or clopidogrel is warranted to try and limit and reduce the likelihood of those problems. Okay, so let's turn to a different form of jaundice, and this is a 6-year-old entire Jack Russell who presents with lethargy, anorexia and vomiting. Slightly longer history. This has been going on for about a week to 10 days prior to presentation. This dog hadn't been vaccinated, so can't blame that for what was going on, and hadn't been abroad, and had had no current or recent medication. On physical examination, and I'm not sure if the colour is obvious on this, but the skin was jaundiced, and he had tacky and icteric mucous membranes. There were no particular echymoses anywhere on him, and on abdominal palpation he was a bit uncomfortable. He also was quite markedly hypothermic at 39.8 degrees pyrexic. So hematology was performed, and you can see that straight away there's a few abnormalities. Important to say that the hematocrit pretty normal, low end of the normal range, but would not fit with a prehepatic jaundice. So already, just with that one test, we've moved our problem away from overloading of the system to either a problem with the within the liver and potentially cholestasis there, or with the excretion of bile and a post-hepatic. So hepatic or post-hepatic when we see a normal hematocrit like this. Doesn't mean that we've got a perfectly normal hematology profile. In fact, there is quite a significant thrombocytopenia, and that was confirmed at smear, though, as I've said, there was no petechial ecchymosis seen. It was nonetheless quite a significant issue. There was a neutrophilic leukocytosis as well, and mild monocytosis. So let's turn to the biochemistry. In this case, you've got a mild hypoalbuminemia. Come back to the C-reactive protein. That's really just a marker of acute inflammation. It's a useful acute phase protein, but it lacks specificity. So if we look back at Lieber, she was about 100 as well. So these aren't helping us really differentiate. They're telling us that something's going on and this dog is facing an inflammatory challenge. It doesn't necessarily tell us the nature of it. There is an azotemia, quite a severe azotemia in this case, as you can see. And the combination of azotemia and hyperbilirubinemia with mild increases in the hepatocellular and cholestatic liver enzyme activities is concerning. And I would already or immediately be thinking, remember that Milo isn't vaccinated, there is a thrombocytopenia, there is a neutrophilic leukocytosis. Alarm bells should be ringing about an important zoonotic condition, and we should be immediately taking sensible PPE precautions to protect members of staff that are handling this patient because of the suspicion of leptospirosis. So for me, any dog with a combination of azotemia and increased bilirubin has to be a potential lepto suspect and should be managed accordingly until you've got a confident alternative diagnosis, and you can maybe reduce those patient handling precautions. As I said, bilirubin was high, and actually in this case it looks like the cholestatic enzyme activity is disproportionately increased compared to the hepatocellular, and that might be something that makes you think, well, is that going to be more of a post-hepatic problem? But as you can see, it's not as specific a finding. So that ratio, if you like, is not actually that useful a diagnostic test. It can guide you, and in cases where you've got significant hypercholesterolemia, increased ALP, GGT, you might be thinking of cholestasis. But in this case, I would still be suspicious of a hepatocellular issue. I've mentioned the azotemia already. We did urinalysis, reasonably concentrated, well concentrated at this stage. Interesting that there was a little bit of glucose on the dipstick, and tubulopathy is well recognised in lepto patients, so that's another warning sign. Worth looking to see if you see any bacteria, just because pyelonephritis would be another potential cause for the azotemia. None seen, still I would submit a culture, especially as there is a mild pyuria there. Abdominal imaging was performed, and I think abdominal imaging is really a key diagnostic test. You've identified that you've got hyperbilirubinemia. You've excluded pre-hepatic jaundice. So now you're trying to differentiate between hepatic and post-hepatic. And ultrasound, or some form of abdominal imaging, is going to be the key modality to try and aid that. Because if you're seeing an obstructive biliary lesion, you might be noticing dilation of the biliary tract. But if it's hepatic jaundice, you're really going to be focusing on the liver and looking to see if there are any structural changes there. And in this case, in Milo, it wasn't enlarged and it was a slightly hypoechoic liver. There wasn't much evidence of gut movement, which may be why he's been vomiting more recently. Mild enlargement of the hepatic lymph nodes could be a reactive change, wouldn't completely rule out neoplasia. So if they are accessible to aspiration, that can be a useful diagnostic test. Seen occasional cases of hepatic lymphoma as well, and they can sometimes be diagnosed in this means. There was mild bilateral pyelectasia as well, which fits with the concurrent renal challenge. So really, based on that ultrasound, the important thing from my perspective is that we've, to all intents and purposes, found no evidence of post-hepatic jaundice. We've been able to evaluate the biliary tree. There's no evidence of any obstruction. There's no evidence of any dilation. Pancreas looks normal. So really, we are focused in that this is going to be a primary liver problem. And what type of liver-based problems can we get? Well, the liver is a very important organ at filtering and processing a lot of the body's blood, and so it is particularly susceptible to toxic challenge. And this might include ingestion of your amanita mushrooms, look like Super Mario, aflatoxins or xylitol, chewing gums. If you are suspicious of any of those exposures, there might be other additional clinical signs, especially with xylitol and hypoglycemia. The dog might have been observed to do it, so depending on timing, is it appropriate to administer an antiemetic such as apomorphine or to give some absorbent molecule? We will see heavy metal intoxication. Now, probably copper hepatopathy, well recognised in Bedlington Terriers, but also in Labrador Retrievers. And in Bedlingtons, it's going to be due to the COMD1 mutation and the inability to excrete that copper. So not necessarily excess copper exposure, but more the body failing to clear that copper from the liver. So it will accumulate and ultimately damage the liver, sometimes leading to terminal hepatic insufficiency. But other heavy metals, iron, lead, arsenic, can also cause liver damage and ultimately lead to jaundice through that route. Medications that we use can cause hepatocellular damage, and there are some that we're very aware of. Phenobarbital, used to treat epilepsy, will naturally induce significant increases in the liver enzyme activities, sometimes rendering them no longer a useful means of assessing the damage to the liver. And bile acid stimulation tests may be necessary to assess how well the patient is tolerating that drug administration. Azathioprine has been observed as an idiosyncratic hepatotoxin. I think if you get exposed to that and experience a case of hepatopathy associated with azathioprine use, it can scar you and put you off using that drug in the future. Certain NSAIDs can occasionally cause liver damage in some patients, and we know that lomustine, which is a very useful chemotherapeutic agent, there are some dogs who are unable to tolerate it from a hepatic perspective. And actually there may be some value in those dogs receiving hepatoprotectants at the same time if you want to try and limit damage from that particular chemotherapeutic. If it's not things that we're giving the dogs or they're exposed to, infectious conditions can damage the liver. Certain bacteria, and I'd include in this E. coli, obviously leptospirosis, mycobacteria, rare in dogs, Clostridia can damage it, but there's also certain viruses like the CAV1 and even certain parasitic diseases, Echinococcus, can cause damage. Protozoa, Toxoplasma neospora can cause liver damage. and less so in the UK. There is some certain fungi that can cause sufficient hepatic damage to cause jaundice. And the final category, shouldn't forget, is neoplasia. Hepatosplenic neoplasia, lymphoma can cause jaundice, as can mast cell tumours, which are occasionally identified either as primary, but more commonly as secondary spread to the liver. Histiocytic sarcoma in your flat coats can sometimes cause quite a severe hepatic jaundice, and obviously the liver is a site for secondary metastases, hemangiosarcoma, for example, found there. So there's quite a few possibilities, and it might be that we know what it is through observed recent exposure. It might be that we can say, well, this dog's been on azathioprine for a certain amount of time, so that would be an obvious culprit. We can test for certain bacterial or viral infections. And you might be able to aspirate. So if you aspirate the liver, you can sometimes pick up some of the more exfoliative tumours, such as the three round cell tumours mentioned there. Cases of copper toxicity can be harder to identify based on cytology alone, and may require hepatic biopsy, potentially also copper quantification, either with special staining or actual measurement of the copper quantity in that liver sample. So back to Milo, he underwent testing for leptospirosis given the clinical suspicion, and this can be done in a number of ways. In the first 10 days of infection, leptospira can be identified by PCR in either blood or urine, and it was found at a moderate level in his urine sample. And you can also use serology. It takes a while, up to 10 days, to start generating that serological response. So early on it may not be as evident, but you can use paired serology 2 weeks apart to see if there is an increase, significant change in the serological levels. But actually, in his case, at the time of running this sample, which I think was actually about 2 weeks after initial presentation of clinical signs, he was positive for a number of the serovars on the leptospirology MAT. So how do we treat Milo? Well, we treated him with supportive therapy for his kidneys in the form of intravenous fluid therapy, antibiotic, initially with amoxicillin clavulanate because that could be administered intravenously, but once he was eating, he was transitioned over to doxycycline to try and eliminate shedding of the leptospires. He was put on some antiemetics and given appropriate analgesia given the abdominal discomfort. And over the course of about 5 to 7 days, he made a steady and encouraging recovery. So I mentioned some of the hepatotoxins, things that can damage the liver, and it's worth mentioning we can actually try and protect it as well. And this may be done using certain antioxidants. And if I was to be treating a T-cell lymphoma and trying to use lomustine as part of that protocol, not unusual that I would add in at least a short course of S-adenosylmethionine, likely denamerin, to try and protect the liver from the hepatotoxic effects of the lomustine. And it works by preventing oxidative damage and limiting the depletion of hepatic glutathione. And there may also be some additional anti-inflammatory properties of that drug. So there is a paper that demonstrates reduced liver damage with concurrent use of denamerin when giving lomustine in these patients. So I think that's a reason to certainly consider it. Silibin is the active ingredient from milk thistle and is a good free radical scavenger, so again will help us with its antioxidant effects in trying to limit hepatic damage from some of these recognised hepatotoxins. Well, that's the paper that I mentioned advocating the use of denamarin to reduce lomustine-induced hepatopathy. Finally, N-acetylcysteine. It's actually, the time I've used it has been to treat paracetamol intoxication, and I've done that more in cats than in dogs. Cats tend to go blue while dogs go yellow with paracetamol intoxication, and the blue is due to methemoglobinemia in that case, and cyanosis associated with it. The dogs sometimes can develop jaundice associated with paracetamol intoxication, and N-acetylcysteine is useful because it can replenish the hepatic intracellular glutathione and cysteine concentration. So try and restore normal hepatic function. And the final drug to mention, ursodeoxycholic acid, a very useful choleretic and a hydrophilic bile acid. So you're going to hopefully increase the proportion of hydrophilic and reduce the concentration of hydrophobic, which are more toxic bile acids, and it also potentially has a cytoprotective effect. So a really useful drug, and a drug that I would use quite commonly also in post-hepatic jaundice. There is a question mark over whether increasing potentially the volume of bile could exacerbate an obstructive problem. That hasn't been my experience, and I think that actually the evidence that aggravates the situation is quite limited, and typically I would use this in those cases. So, final case, just to finish this talk off, is Toby. He was a 10-year-old castrated border terrier who presented with a 5-day history of vomiting, inappetence and lethargy. We're saying that each of these 3 cases presenting for jaundice, though they have different mechanisms by which they've developed the jaundice, have presented with quite overlapping clinical signs. And Toby, on his blood work, his hematocrit was within normal limits, so not consistent with pre-hepatic jaundice, not really a significant significant leukocytosis, and neutrophils are within normal limits, as are platelets. Non-azotemic on this case, but you can see that there is an increase in his liver enzyme activities. In this case, ALP greater than ALT. There's also, unlike in Milo, there's quite a very significant increase in GGT. So maybe further evidence of cholestasis, and cholesterol is increased as well quite dramatically. So when we're talking about hepatobiliary disease and more of a post-hepatic problem, ALP is not a specific marker. It is a cholestatic liver enzyme activity, but it's also induced by steroids and certain other medications, and so lacks specificity. GGT is more specific, so increased GGT lends greater weight that we're going to be dealing with some form of cholestasis. If you get both of them increased, you're up to a 94% specificity. This is going to be hepatobiliary, so more likely post-hepatic in this instance. And so we still couldn't be certain, and we were saying, well, is this going to be a pre-hepatic or a post-hepatic? And again, abdominal ultrasound way forward to try and differentiate between those 2 possibilities. And hopefully you can automatically give the diagnosis. This is the liver surrounding the gallbladder, and you can hopefully make out, if you squint carefully, the sort of cross-section appearance of a kiwi fruit. This stellate arrangement is pathognomonic for a gallbladder mucocele, and that's what Toby had. So that's our diagnosis. What can be seen on the ultrasound is a gallbladder mucocele. And we know now that Border Terriers are massively overrepresented, and the UK seems to be somewhat unique in this. We're big fans of Border Terriers, I think, in this country, but for some reason they seem to be storming to the front in terms of numbers of gallbladder mucoceles, and certainly at the practice that I work in, they now represent over 50% of the cases of gallbladder mucocele that we see are Border Terriers. But what other breeds does this affect most commonly? There are some textbook breeds that have been well recognised as presenting with gallbladder mucoceles, and just to give you a few examples of those, there's the Sheltie, the Shetland Sheepdog, our little miniature Schnauzer, Chihuahuas also, Pomeranians. In some of the American literature, they talk about the American Cocker Spaniel, but actually when we did a study in the UK, we found that Cocker Spaniels were less likely to get it and seemed underrepresented. We did agree with the other predispositions. And for us, Border Terriers and also Affenpinchers seemed overrepresented. And why does a gallbladder mucocele develop? What underlying conditions can this problem be associated with? So it can develop without an identifiable underlying condition. Rare that it comes up in associated with cholecystitis. Only sort of 1 to 5% of our cases have had a positive biliary bile culture with their gallbladder mucocele. So I think infection is probably a low risk aspect. Any other things that people can think of that might contribute to it? Well, endocrinopathies are the main ones, and in particular Cushing's. Cushing's increases the hazard ratio by about 27-fold, so a major risk factor for the development of Cushing's, of a gallbladder mucocele, sorry. We also see it in hypothyroidism, and interestingly, a couple of dogs presenting with gallbladder mucoceles and hypothyroidism, their gallbladder mucocele actually resolved following treatment of that hypothyroidism. So thyroid supplementation led to a disappearance of the gallbladder mucocele. So worth looking for that, and if your patient is compatible, it might be difficult to actually test for it if they're unwell and they might be struggling with sick euthyroid syndrome. So care in confirming your diagnosis. But if you are suspicious of hypothyroidism and the dog is not overly clinical, it may be appropriate to treat them and see if there is a reduction in the gallbladder mucocele with treatment. Hyperlipidemia, and that may be a reason in your miniature schnauzers, because obviously they're predisposed to hyperlipidemia. And I added neonicotinoids simply because that has been recognised just in one breed, in the Shetland Sheepdog. So if you thought of that, that's fairly impressive. Diabetes, recognised risk factor in 1 or 2 early studies, but that hasn't been confirmed in some of the larger retrospective studies. So there is potential mechanism. It is another endocrinopathy that might be suggested, but maybe less of a risk factor than Cushing's or hypothyroidism. So what should we do? How should Toby be managed? What are the options? Well, it depends really on his clinical presentation. And I think that our position is evolving on this. If it's an incidental finding, maybe you're ultrasounding for a different reason, even for screening reasons, given the rate of this disease in 9 to 11-year-old Border Terriers, it might not be an unreasonable thing to occasionally check a Border Terrier and say, I just want to have a quick look. It can be done consciously, and if you identified either a mature or even a developing mucocele, do we need to jump into surgery? Well, it's quite complicated surgery. We're looking at 10 up to 20% mortality in some studies with that gallbladder surgery, so it's not straightforward. Is there anything else that could be done? Well, they can be managed medically. Obviously, if there is an underlying endocrinopathy, that should be treated. But otherwise, ursodeoxycholic acid, which I talked about a few moments ago, is an appropriate drug and can help clear some of that bile. Value of antibiotics, questionable. Low incidence of infection. And I'd be nervous to try and aspirate bile in a lot of these cases. So I tend not to, for fear of causing damage to the already diseased gallbladder. So the case for antibiotics I would really base on other systemic evidence of an infectious process. But ursodeoxycholic acid alone can be appropriate, associated with careful monitoring and regular ultrasound, and obviously the owner keeping an eye on saying, well, the dog seems to be doing well, they're not noticing any clinical signs of vomiting, loss of appetite, abdominal discomfort, and importantly, no hyperbilirubinemia. For me, if they're already icteric, I would be worried that the likelihood of resolution with conservative management is probably quite low. And in those cases, going to cholecystectomy is likely the appropriate way, or as I say, it's quite a high morbidity and mortality type of surgery. So just to finish off, the little bird that I put up at the start, actually called Icterus icterus, and is the national bird. It's a Venezuelan troupial, so the national bird of Venezuela. So that's probably the fact of the day, and the only thing that people may remember from this presentation, but it is called Icterus icterus. So what's just a couple of minutes to reflect on and to the take-home message for this session. It is important to think carefully about how you classify jaundice. Work through that diagnostic algorithm. Is it pre-hepatic, hepatic, or post-hepatic? And how can you differentiate between those things? Important to do a hematocrit. Exclude pre-hepatic jaundice. And then look at liver enzyme activities. Can you start to get a feeling of whether this is going to be more likely hepatic or post-hepatic, but try and confirm that then with your abdominal imaging. Ultrasound, I think, would be the way to do that. Thank you very much for listening. I hope that it is still a useful session, and if you do have any questions or comments about the presentation, please don't hesitate to get in contact with me. My email address is here, fergus.allerton@willows.uk.net, and I'd welcome any questions and try and engage with any feedback. Thank you.